Time now for this week's Health Matters. Paul Critz with you, along with Del Norte's PA, Lynn Szabo, and we're joined on the phone this week by Dr. Michael Fratkin, calling up from Humboldt. He is, he's called himself a palliative care pioneer. And what was the rest of it? A palliative care pioneer who's established a great organization that's doing terrific work. Was that basically it?
Yeah, that's basically it.
That covers it. Cool. Well, thanks for joining us, and we'll talk next time on... No, that's... So we're discussing palliative care. Lynn has a list of questions for you. I'm going to let her take it away and sort of get the conversation rolling. And then as we move into plans for the care you provide, expanding into Del Norte, which is an exciting thing healthcare-wise up here for us. So Lynn, take it away.
Okay. Hey, Dr. Fratkin, can you tell us about yourself? And then also, maybe this really is a question about what can you tell us about ResolutionCare and how what your role is in it?
Yeah, well, first of all, thank you to you, Paul and Lynn, and also to the listeners in Del Norte. I have been in the community since 1996 as a part of primary care community clinic system, and spent my first few years going back and forth between Crescent City and Eureka and Arcata, providing kind of complex condition care, internal medicine support and consultation in the community clinic system. And so I've been close to Crescent City for a long time. In fact, for a few years, I did some work at Pelican Bay and have been a collaborator in the initiation of the cancer program at Cedar Coast Hospital. So it's not like we're new to Del Norte, but I'm glad to speak to the community directly this way and tell a little story about myself, my evolution, and why we created ResolutionCare to scratch a very, very big itch in our community. Yeah. Well, I'm an internal medicine doctor as well as a specialist in hospice and palliative care. And for many, many years, I was trying to find my place. It was really hard to find a sustainable working situation that didn't just kind of take the life out of me and take the spirit out of me and work me to the bone beyond my breaking point, but to find a way to build the kind of team-based care that palliative care really is. And so the truth is that ResolutionCare was born in 2014, 2015, really on a foundation of burnout, my own frustrations and the frustrations of my beloved colleagues, the fantastic nurses and doctors, social workers, chaplains, ancillary staff, that all just want to do work of meaning and purpose for people with serious, serious illness in a way that doesn't crush them. And I was feeling crushed in 2014 and 15. So I pulled a rabbit out of the hat to really put a point on it. In 2014, I became so frustrated with the hospital system that I was working with and my inability to get the resources to build out a whole team. I went to the community and started a crowdfunding campaign at the end of 2014 and raised enough money to get started.
I didn't know that.
You didn't know that?
No, why didn't I donate?
I don't know. Why didn't you donate? I know that there's at least 5 or 6 people I could actually name from Del Norte County that did donate.
but you aren't one of them.
You weren't one of them, bro.
Dr. Fratkin, if I could jump in really quickly, I'm curious, just briefly as an aside, what was it about the work you were doing before that was leading to burnout? What were the things that you needed to change?
Oh, the pressures in the American healthcare machine for productivity, excessive documentation, all the process work, and everybody running to do more with less as the sort of economic forces defining the healthcare delivery system in the country.
Wow, okay.
And that produces a lot of access and capacity for most people dealing with most reversible things. But the heartbreak for me was that my interest was working with people who were very, very seriously ill. People that, in addition to whatever their medical complications were facing and are facing, profound human challenges, huge challenges and struggles against the presence of mortality or continuous losses of function and abilities and freedoms. People really being confronted by their vitality and even their length of life diminishing over time. They're dealing with illnesses that would take their lives, maybe not tomorrow or even next year, but illnesses that brought mortality into their existence and losses. And for those people, great medical care is very important, medical care for their illnesses, diseases, and conditions. But in addition to that, what's important is that they're seen not as patients, but as the people that they are.
Mm-hmm. That they're heard.
That form of distress, of having to kind of just walk past all that human suffering without addressing it directly, without having the time to really sit down, without having a team that can look at what they were facing from all the dimensions, social, spiritual, practical, mental health issues, all those kinds of things. Just having to crank it out and move them through was heartbreaking to me, and honestly to lots and lots of totally dedicated human healthcare professionals.
I'm really intrigued by that, and I know Lynn has a list of questions here, and some of them are very important about Del Norte and about the differences between palliative care and hospice care, things like.
Yeah.
But how do you assemble a team to address these things, to address the extra medical things, the not just the nuts and bolts, but the spiritual and the societal? I mean, what sort of team do you put together to address those aspects of someone's end of life?
Oh my God, the most amazing human beings. And what you have to do is you have to support them in a sustainable structure. They have to have their shoulders hooked together to be willing to walk towards the kinds of problems that everybody else is running the other direction from. So typically it's a model that's based on what we learned in hospice care for people at the very end of life. When hospice is a incredibly robust model that's organized around the very last part of life, when people have exhausted their interest and desire to continue to partake of the disease-directed care, hospital visits, labs, visits to the doctor's office, more disease-directed therapy, chemotherapy, surgery, those kinds of things. When they're done with all that, hospice in 1982 was formed with some very specific components, with a physician expert in symptom control, with social workers who have their eye on the family and the systems of care and what we call the social determinants of care, the practical resources and meeting the needs of people that way, food, shelter, clothing, transportation, that sort of thing. Nursing that helps a doctor's really well-made plan actually get executed effectively by teaching and monitoring, evaluating, reevaluating, and adjusting the interventions to deliver results as quickly as is practical. Spiritual care with non-denominational chaplains that look at a person from a very unique perspective, not just as the person that they are in the life that they lead, but in terms of their sense of spirituality. For some people, that's religious. For other people, it's related to feeling the sun on their face and treasuring that. And the hospice model was so smart in saying that, yes, you need all these perspectives, but these perspectives have to be integrated with each other. You have to build team, and you make that team a little bit flat, so that the doctor doesn't necessarily dominate or the nurse doesn't necessarily dominate, but you put together these structures called interdisciplinary teams that talk about each person, each family, each situation on a regular basis and look at them from 360 degrees around. That hospice model is very robust and very intensive in the very last part of life. But it turns out that lots of people are facing very serious issues, very serious medical problems, and their mortality for many, many more months and sometimes years.
Yeah, can you define what the bottom line timing that defines hospice? You haven't really said that.
In a perfect world, smarty pants doctors would be able to say, this person now has a, quote, prognosis of 6 months or less. And that was the way that they defined the hospice benefit. But the truth is that doctors really stink at making those kinds of predictions about the future.
True.
And doctors are very concerned about being right and accurate. So it turns out, even though the hospice model defines eligibility of a 6-month prognosis, it turns out the average length of stay of hospice care in communities that have access to hospice care is less than 14 days.
Wow, yeah.
Now, these are people that may have been dealing with a long journey with cancer, or up and down problems with congestive heart failure, or liver disease that lingered and progressed over a period of years. And they had all kinds of needs long before they were eligible for the last couple of weeks of care from hospice. Hospice does beautiful work in the very end of life, but unfortunately most people don't have access to hospice, or if they do, they have it for a short period of time. So enter this concept of palliative care or palliative medicine from a physician's point of view. In that upstream world, people are continuing to go to their primary care doc. They're continuing to go to their cancer doctor. They're continuing to be evaluated for things that come along the way. At the same time, they're dealing with the reality of very, very serious illness. And what we do is we add our support to that they're receiving from the standard routine elements of the healthcare system that they're accessing. So they're working with their cardiologist, and we're working to make sure that the medicines the cardiologists are prescribing are actually being taken in the right way. We lean into helping them make sure that they're making choices that give them the best possible quality of life, while the cancer-directed doctors and the cardiologists and the pulmonologists are working to extend life and to optimize physiologic function. We're focusing on the whole picture and helping them to optimize the experience that they're having being alive. And for us in the eligibility requirements with our contracts with health plans, we don't have to predict that. We just have to say that these people are eligible if we wouldn't be surprised if, as a result of their clinical conditions, they passed away in a year.
Okay.
1 year. And our average duration of time, the ResolutionCare, a palliative care program, seeing people in their homes, our average length of time is about 10 or 11 months where we get to join people.
Wow.
And as they make their way down. And then we pass them along, at least in the communities where hospice is available, we pass them along smoothly to the hospice program, and they probably get a little bit more time getting the more robust support that comes with hospice than they would otherwise.
How did you come to specialize in palliative care?
I fell in love with the mysteries of human beings. I did it long before I thought I was ever going to be a doctor. I was working in the emergency room at Tampa General Hospital, and I was an admission clerk and then an ER tech. I did a basic EMT training program, and they gave me a clipboard, and they told me to go into these crazy little trauma rooms where there's 10 people cutting at clothes and getting x-rays and putting in IVs. They said, go in there and find out who these people are and who you should call and connect with them and get them registered in the computer while the whole trauma chaos was unfolding. And I discovered that the only place I could stand and not be in the way was above their head.
Mm-hmm.
So I would sneak in around above their head, and I would talk to people upside down. I would look down at their face, and I found myself talking to them about what was happening to them while gathering whatever information from my clipboard, but I found myself wondering and paying a lot of attention to how they navigated that experience, how the person inside of that whole traumatized body, diseased body, medically troubled physiology. I found myself looking dead on, eye to eye, upside down or otherwise, with people as they were having an experience of going through our healthcare system.
Wow.
And that landed for me. Like, I realized that what's wrong with them is different from who they were. And that was sort of the earliest kind of indication that I was interested in the people having the medical challenges, not just the medical challenges themselves.
Can I throw in the time I worked with you around Y2K, that you always seemed to be most drawn to the sickest people? And I especially appreciate your work with the HIV positive in the community. And I don't want to say names or anything, but I vividly remember you at the end of the day being exhausted and saying, but it's so-and-so, no boundaries, like you were talking yourself up to making sure that person got everything they needed. Everything
I
they
just
needed.
realized it's so meaningful to me now, sort of through this incredible team of healthcare professionals that I lead. But it's always been super important to look them in the eye, understand what itch they need scratched, and then to scratch it. Like, getting people to feel better and grounded in what's actually happening to them, balancing what can be done with just what's so, but joining them and in understanding of how hard it is to deal with losses and to deal with the loss of your own life. It still motivates me every day.
So can I ask you, you haven't explicitly said this, but I'm a PCP right now at UIHS, and one thing that ResolutionCare does is it works in conjunction with the primary carers. And what I've found out in talking to administrators and both the community clinic systems is they kind of expect the primaries to do all this, but yet you guys are like set up to do this, and you guys are so much better at it, especially with pain management. Can you talk about the interface between ResolutionCare and primary care?
It's tricky. I don't want to say to hardworking primary care environments that we're, quote, better than them.
You're not better. You're appreciated.
But there is that perception. People are very protective and feel a sense of ownership of the folks and feel a sense of responsibility. Yeah. And even though they don't have the resources to address the broad interdimensional needs of people as they get very, very sick. And it's true for most people in most circumstances, the bell-shaped curve, the middle of the bell-shaped curve, these incredibly dedicated primary care environments that have been scrappy and resourceful and innovative provide really solid and pretty comprehensive care for most of their patients. But as people become more specially defined in the context of impending death, we wish to add a bunch of dedicated resources alongside of the primary and specialty care that they're getting. And their experiences are better when they receive more thoughtful support. For example, our folks that may see their primary care provider every month or two in the context of terrible heart failure or worsening liver failure, or even developing resistance to chemotherapy for metastatic cancer, they may see their primary care doctor every month for medications or every 2 months for follow-up. But our team sees them for a total of 5 to 6 hours of direct contact time with dedicated nurses, social workers, chaplains, and physicians. And we end up not waiting for a month to go by to make an intervention that'll make a difference.
And even more simple.
Day to day.
Even more simple things, like I tried to get a bedside commode for a patient who was at home, and it was going to take weeks to get it. The guy didn't have weeks, but But you guys, when I talked to maybe him signing on with ResolutionCare, you guys were ready to go in 4 days over a holiday weekend. So amazing ability to kind of bring what a patient needs. And the family. Yeah.
That's the way we roll. And it's an ongoing conversation with primary and specialty docs who need, for their own well-being and their own sense of meaning and purpose, they need to think that what they're doing is really, really, really good care. And it's a ongoing conversation to say, yes, it's really, really good care, and we can add value and make your job easier while supporting the maintenance of that relationship, which is so important to these folks. And, time and time again, person after person, we put points up on the board, but it's still a long conversation because it's hard to understand how a very person-centered model with an interdisciplinary team fits into the world of sort of disease-directed interventions and care.
And then you also add spirituality in that, which is, I think, unique.
I think it's unique, but it's like the air that I breathe. I have my own sort of sense of purpose and understanding of myself as a being, as a man, as a father, as a husband. Those things are what guide me all day long, every day. And so when I deal with people that are faced with illnesses that are likely to take their life, I know how front and center it is for them, even if they can't articulate it.
So you're familiar with the healthcare scene in Del Norte, of course, and the kind of folks up here, and how in the world, and you also are familiar, I'm sure, with what's available for us up here. How in the world can Del Norters access the care offered by ResolutionCare? You're expanding, is that correct?
Yeah, no, we are endlessly expanding. In fact, we've more than doubled our census in the last 12 months. We were taking care of 200 people all over the state of California about this time last year. Now we're taking care of like 525 people.
Wow.
And I'm all over the state of California, from the border of Mexico with a couple of folks in India, all the way through the Central Valley and in and around the Bay Area, mostly rural sites, but in collaboration with health plans that want to add this care to what people are doing. Now, we have probably at any given time 20 or 30 Del Norters that are enrolled in our program in one way or the other.
We have
amazing. Yeah, no, we do. And until the next phase of things really unfolds, we've been providing end-of-life care for many folks in the community and helping them to finish their lives at home if that's what they want and if that's possible. We have been doing essentially virtual hospice care in Del Norte. We have an amazing nurse that many of the listeners probably know because she seems to know absolutely everybody in Crescent City and Del Norte.
Yeah.
Kathy Mize.
Love her.
Everybody seems to love her, and I sure do. And so she's been working with us for well over 6 years. And we have a community health worker up in the community as well. And so we've been doing our best to take people all the way to the end of their lives, to the best of our ability with a mostly virtual care model.
What's that look like? Mostly virtual care in a situation like that?
Well, I'll tell you, when we launched ResolutionCare in 2015, we specifically wished to innovate by the use of telemedicine. And so we were the first in the country to begin using telemedicine to connect with people in their homes. And all through that time, I wanted to make it a bigger and bigger proportion of what we do because I am so impressed at how much better than real life it is.
Really? My assumption, my feeling would be that would be that's counterintuitive to me, is you're looking for spiritual human connection like that, and you're finding you're able to actually do that from a distance using technology.
Absolutely. I'm going to circle back to put a pin in that, Paul.
Okay.
But I wanted to give you a sense of the arc of things. So when we started into the pandemic on March 19th, 2020, before they shut us all down, We were doing about 40% of all of our nursing, social work, and physician and chaplain encounters by video. And I couldn't encourage my team to go any further because they so loved to drive around and put their arms around people and to hold them and hug them. And that was so intrinsic to their sense of value and their feeling like they were really demonstrating or expressing care. But on March 20th, 2020, when Governor Newsom closed us down, we went immediately to 100% telehealth. Whereas most healthcare delivery systems or clinics or specialty care freaked out and had to deal with all of the complexities of making that work. Right. For us, it was just like we toggled a switch and everybody knew how to do it. And for the first 3 months, all the staff complained, like, when do we get to go back? When do we get to go back? And I was like, we're not going back. And they said, what, how do I feel important? I said, we're not going back. Get used to it. Figure it out. And after 3 months, we had given them more freedom to manage their own lives in the stressful time of the pandemic, right? And we as healthcare professionals and every citizen had to cope with all kinds of changes and stress. But we gave them a work experience that gave them a little bit more room to homeschool their kids and manage their own lives inside of a really unusual new routine. And after about 3 months, even though some of our patients complained about it until we got them up and running, it became the new normal. And people then began really studying on how to use this platform to make it really deliver. And since then, nobody's complaining about it, and everybody gets how it is better than real life.
And you don't you don't have any problems with bandwidth in Klamath is a disaster. And maybe somebody who's elderly, like I cannot imagine my parents being able to join a Zoom meeting. It would be beyond their technical ability. But you're able to kind of rise above all that, huh?
We just put in the time, and we're scrappy and resourceful and playful with people, and we overcome those kinds of areas. Because it really is, when it comes down to it, a handful of clicks and just buying in that this is as soon as they do it, they never want to go back. Right. They never want to have to schlep themselves to the clinic. They never want to spend the time it takes to travel, throw their wheelchair in the back, have their daughter take a half day off of work, go to the clinic where they shove that clipboard in their face again and sit them down in the waiting room. And it's always running late, and all the front desk people are talking about their nails and their, problems and whatever, and the news is on the screen blaring, and everybody's looking at each other like, is that person sicker than I am? Am I sicker than them? Didn't I see them last month? And boy, they look terrible. Those kinds of things, and the 10-year-old People magazines and all that stuff, so they can get shoved into a windowless room with some strange diagram of a pregnant person sliced in half, some kind of anatomical. And then they sit there and wait for the doctor to come.
Yeah.
And it's cold.
And maybe
then wait for
they're disrobed. Yeah, it's awful.
Well, since you put it all like that, I can see the appeal of telemedicine now. But that's.
but Paul, there's one more thing, right? There's also other sites that you see people. So bringing people into your clinic, that's a thing itself that has a lot of downside to it. But actually walking on the door and walking into somebody's home, that is a very power imbalanced situation. When a doctor knocks on the door to do a home visit, as honored as a person is, and as informationally rich as it is for the doctor or the provider,
right?
It's kind of a home invasion.
Yeah,
you're in their space.
Yeah, no, I can see that. It's almost like a leveler of that dynamic to both be sitting in front of a screen and talking like that.
Totally a leveler, and within seconds, the screen itself disappears, and what you have is a window into their world, and they have a window into yours. They show you what they wish to show you, and you show them what they wish. And what happens is that the intimacy is much easier to establish because they're relaxed in their little happy place with their cat on their lap and a cup of tea. And you're sitting in your happy place, my little home office that I've got decked out to be comfortable with me. And boom, within a couple of seconds, we're in it. And it's intimate because it's well framed with a perfect boundary between them. So if I want to know, say, how they manage their medicines or how they store their medicines, I ask them, will you show me where you keep your medicines and how you get them organized? And then they pick up the computer or the phone and they take me there if they want to. If they don't, they're like, I don't want to. If I want to know what their garden looks like and what kind of shape their tomatoes are in, if they want to show me that because they're proud of it, they can show me that. And I tend to have this like little quirk where I like to look into people's refrigerators. I like to ask them.
That's actually in a food desert like Klamath. That's kind of significant.
That could be, yeah.
Yeah, totally.
Yeah. Wow.
It can be very enlightening.
Totally.
So it turns out it's more efficient, it's more respectful, it levels that power dynamic, and more work gets done more directly than in any other context that I've worked in healthcare.
So how does one pay for these services? What insurances does ResolutionCare accept?
Well, for the longest time, our contracts with health plan partners like Partnership Health Plan and Blue Shield of California and HealthNet were all that we could afford to work with. And the way that those contracts allowed, they said for people who were eligible, we would get an amount of money per month, and that would be our budget that we would use all of our resources. Some people we would touch lightly and make a little money, and other people would take a lot of heavy lifting and we'd lose money on them. But at the end of the day, working with the population, we came out slightly ahead. As we've grown and the economies of scale have improved and we aligned forces with a digital health company called Eureka, we have more resources to work out some different models. So now, in addition to Partnership Health Plan and Blue Shield for eligible folks, we have a program for people who have Medicare as a primary, and we provide a somewhat less intensive model for them called the Parallel Pathway. And for those folks, if they've got the ability to connect, if they've got adequate caregiving, if they don't have overwhelming social determinants of health chaos, we work with them over time and see them on a monthly basis, help them with symptom control and empowered advanced care planning and just showing up for them as they're going through what they're going through.
Wow. And is it a matter of just going to the website? Is a referral needed? How does somebody get the care that you guys provide?
Well, I'd like to, for the listeners, to pull out a pencil, and I invite them to look at the website and see a lot of information. Just quietly look around and see how this organization feels to them. And that website is www.resolutioncare.com. And then our phone number, if they want to inquire on whether or not what we've got matches what they need, our number is 707 445. Is that right? Yeah, no. I'm gonna go. Hang on.
442.
No, it's. Hold on. I'm gonna make sure I get this right, because I wouldn't want to steer you wrong. There it is. Yeah, it's 707 442 LOVE. LOVE.
Look at that. That's perfect. Wow. Okay.
442 LOVE. And it's 5683 for those who don't want to do the spelling challenge.
So just to sum up again for listeners, because I always like to hear things like that twice. ResolutionCare.com is the website.
Yes.
And the phone number 707-442-LOVE or 5683.
Correct, Paul.
Awesome.
And I want to talk before we close about something that's coming to the community that we're really pleased about.
Oh, okay.
The Brookings-based Coastal Home and Hospice program for a long time has been dedicated to the project of bringing fully composed Medicare-certified hospice services to Crescent City and that service area. And finally, after an incredible amount of work, they are very close and in the credentialing and accreditation process. I spoke to their leadership yesterday just to kind of get clear about what they were doing, and they are going to be bringing full hospice services to Crescent City and the service area, hopefully by September. There's a bunch of regulatory credentialing steps that they have to do, and in fact, the nurse that they hired is a nurse that we loved, that worked with us for quite some time. Blakely Winter is known to many people for her work at Sutter Coast Hospital, as well as just an extraordinary woman in the community.
Really helpful during the COVID thing. She did a lot with the organizing immunization clinics. Yeah.
She's an extraordinary nurse. And she's a great first nurse for the community in hospice care, and we were sorry to lose her, but she's also a bridge, so that rather than us doing the best we can with people in the very last part of their life, we're going to have a warm handoff to an organization that's got a whole economic structure and model that will do a better job at the very end of life than we have been able to do over these last 7 years.
So we're really excited. Yeah, such good news. Hey, we're getting kind of down to it, and I want to ask a specific question about something I saw on your website, and also I saw it in your office when I would, kind of pass through. You have a beautiful mobile with lots of beautiful, looks like sun or ocean smooth stones that are hanging. And when I remember in the beginning that you maybe had like 5, and now it looks like the photograph on the website shows many more than that. Can you explain what that is?
Yeah. This is a tribute to my relationship with St. Joseph's palliative care social worker, Natalia Szabo. As we were doing work over the years in the inpatient environment, people would come and go. We would take care of people, and then they would die. And we had no real mechanism to sort of mark those individuals after they had died. So we put up this sculpture, and my daughter helped me design the first one, and we called it a spirit gate. It was a few pieces of bamboo kind of tied together, and we hung a stone for every person that died, and we gave a little moment of reflection. We would talk to each other. It was just the two of us in that team. We would just talk to each other about what that person meant to us and what we learned from them. And then we go about our business and our day. And as the months and years went by, we hung quite a few stones on that little bamboo spirit gate. And so that when I left St. Joseph's Hospital to build ResolutionCare, I brought that ritual with me. And so we got a big manzanita branch, and my daughter and I would go to the beach, and we'd pick up these stones, and we'd take them back and drill a little hole in them, and we put them in a box. And then when the team each week would acknowledge the death of somebody we cared for, we'd put a little string in that, and we'd hang that stone on the branches. And like you said, you saw it when it was very few stones. Well, over the years, we filled up that first manzanita branch, and then we filled up a second manzanita branch, and then we moved offices and filled up a third and a fourth. And since the pandemic, we continue to have the ritual, but now we have a box of stones that need to be hung up in the office that nobody has gotten around to doing.
Oh man, it's out.
So every week we still maintain an ever always unfolding stones list, and then we have an honor meeting on Thursdays where we name these people and invite the workforce, the staff, to talk about what those people meant to them.
Wow.
There's on the website, if anybody is looking for it, you can see a little video under the Voices tab, I think, on the website. And it's a 90-second video that kind of tells the story I just told you.
Stories. It's the Stories tab. I'm looking at it right now.
Yeah, someday
Yeah,
show me David Stone, okay? I'd love to see David Stone.
Well,
Someday.
the funny thing, Liv, is that as soon as they hang up,
Oh, you forget who they are.
they kind of lose their human identity. They just become part of something a little less identified with the individuals.
Then I shall
There's a
embrace the
few of them.
totality, Michael.
Yeah, I kind of like that.
Yeah, the poetry of all of that is just striking. That's beautiful. Wow.
Well, don't human beings deserve that?
Hell yes. I'm sorry. Dr. Michael Fratkin, palliative care pioneer, is there anything that you wanted to make sure gets said and gets heard that we haven't asked or given you the opportunity to say tonight?
It's just in talking to the community and talking to people living in their houses and dealing with what they're dealing with. If they're faced with a very serious illness and their mortality, to ask for this care, to ask for more help, to ask for support, to acknowledge the good care they're already receiving, but ask if it's possible for us to get more help through a palliative care service. Whether it's us or somebody else, I don't really care. I just want people to understand that we all deserve to be seen as the people we are while we're going through what we're going through.
That's a wonderful sentiment. Thank you very much, Dr. Michael Fratkin from ResolutionCare. Thanks for speaking with us this evening. Lynn, do you have anything else?
Just thanks, Michael.
Yeah.
I knew you would bring it. Thank you. I appreciate your efforts into my community.
Thank you. It's been a pleasure for 7 years to serve the people of Del Norte, and we'd like to do more. So thank you so much for having me.
All right. That's it for this week's Health Matters. We'll see you again next week, Lynn. Thank you.
Thank you.